Hi there, Dr. Terry Shaneyfelt for UAB Department of Medicine. In this video, I'm going to discuss the perioperative management of a patient with diabetes. I'm going to focus on patients taking oral agents or non-insulin injectables in this video. So there's little evidence, unfortunately, on the optimal perioperative management of diabetes, and much of what we're going to talk about in this video is based on expert opinion. So what are the goals of glycemic control? Well, there are four of them. One is to avoid hypoglycemia. We want to prevent ketoacidosis and the hyperosmolar states. We want to maintain fluid and electrolyte balance and avoid marked hyperglycemia. Now, the optimal perioperative glycemic targets are really unclear, and there's two main bodies that have recommended targets. So the American Diabetes Association has extrapolated information from the general hospitalized patient to recommend that a fasting blood glucose be less than 140 milligrams per deciliter and a random blood glucose be less than 180 milligrams per deciliter. Now, the only group to really make a recommendation for the perioperative period specifically is the Canadian Diabetes Association, which recommends glycemic levels should be maintained between 90 to 180 milligrams per deciliter. The 90 I'm a little bit worried about because of the risk of hypoglycemia, so it seems sort of prudent that we should shoot maybe for the 140 of the ADA into the upper 180 is the upper parameter as put forth by both of these organizations. So there's no real consensus on the optimal management strategy to maintain target glucose levels. So there's a lot of different ways you can do this. I'm going to present one way that's an amalgamation of a variety of sources that I found. Importantly, though, surgery should try to be scheduled as early as possible for a diabetic patient so as to minimize the time that they're NPO and to minimize the disruption in their normal management strategy of diabetes. So let's go through a couple of different types of patients. Again, we're going to focus only on patients on oral agents or injectable non-insulin anti-diabetic drugs. So what about the diet control type 2 diabetic? Well, it's recommended for blood glucose monitoring that they get one preoperatively and then as soon as possible postoperatively. For long surgeries, it's recommended that they have blood glucose testing every 1 to 2 hours during the surgery. Now, most patients who are diet controlled are not going to require any other therapy. Their blood sugars are going to be well controlled on their own or not go high enough that you'd be worried about them. If you do have significant hypoglycemia that you're worried about, you could use a short acting insulin, something like regular insulin, or rapid acting insulin like Lispro. And you want to give that subcutaneously every 6 hours as needed to correct glucose over the desired targets that we mentioned a couple of slides ago. Now, what about type 2 diabetics who are controlled on oral agents or non-insulin injectables? Well, it's recommended to check blood glucose every 2 hours. And the way you want to manage their medications is you want to continue them really up to the morning of surgery. So if they use something at night, they can use it the night before surgery. But on the morning of surgery, you want to hold all these medications. Now, if they develop hyperglycemia, there's different ways you can approach this. So for a short procedure in patients who have very good control, and that means an A1C 7 or less, you really don't probably need to give any correction insulin. For other patients undergoing short procedures who develop hyperglycemia, you want to do similarly what we talked about on the last slide. You want to use short or rapid acting insulins, sub-Q every 6 hours as needed to correct glucose that's over the desired target. Now, for long complex procedures, things like cabbages or large intra-abdominal procedures, you're going to have to use IV insulin. There's a variety of IV insulin regimens out there, and we'll talk about that more when we get to the managing insulin in diabetes patients in another video. And then finally, once patients are eating, you want to restart their usual home meds. Now, metformin deserves specific mention because of the worry about the risk of lactic acidosis, and the data is very controversial in this area. There's many studies showing it probably really doesn't cause lactic acidosis, but nonetheless it's in the package insert and we have to treat it differently. So the package insert recommends that metformin therapy be temporarily suspended for any surgical procedure. Now, temporarily varies when you look at different opinions. The most common recommended time to stop it is 48 hours prior to surgery. It seems like a long time, but surgery can certainly be associated with hypoperfusion of the kidneys. Patients can be sick and have sepsis and have hypoperfusion of the kidneys. So any time that you have hypoperfusion of kidneys or even liver, you want to try to hold metformin. So it seems reasonable to do that. I also think it would be reasonable if you continued it up to the day of surgery in a procedure that you don't anticipate should lead to any hypoperfusion. They further recommend that it shouldn't be restarted until the patient's oral intake has resumed. That makes sense. And that renal function has been evaluated as normal. So what that really means is postoperatively you need to check your creatinine, make sure that the renal function is normal. You don't anticipate any further renal hypoperfusion states, and then you can restart the metformin. But again, the data is very inconclusive here. Some studies showing it's of no harm. There's actually a couple of cardiac surgery studies that show being on metformin right up till surgery is actually cardioprotective and prevents cardiac events. There's no strong big studies in this area, but it's an interesting observation nonetheless. So let's see how much you remember from this. So you're asked to see a 67-year-old gentleman with type 2 diabetes in the CCU, and he's 1 day post coronary artery bypass grafting. As an outpatient, he was taking glyburide and metformin at maximal doses. His last A1C, which was about a week before surgery, was 8.5%. In the operating room, his blood glucose was very variable, running 173 to 310 milligrams per deciliter. Glucose 1 hour prior to you seeing him was 188 milligrams per deciliter. So what do you recommend? So what I'd like you to do is pause the video, look over these options, choose which one you'd like to do, then restart the video, and I'll discuss what I think is the correct answer. So pause the video now. So how did you do? Well, what I think is the right answer is C. So what's wrong with A? Well, A, the target glucose is just too high. Remember, the ADA and the Canadian Diabetes Association recommended blood glucoses less than 180. So responding to a blood glucose over 200 is too high, so that's wrong. B and C both talk about continuous insulin infusions, and I think that is a key component because this was a complex procedure this patient underwent. And the targets are different. So the problem with the first target is just too low. The second target in C is consistent with what's recommended by guidelines. Now D is a reasonable approach. This person was uncontrolled before admission, and they probably are going to need basal insulin at discharge, or should be managed with basal insulin no matter what, since their A1C is not at goal on maximal oral therapy. But it's not a good time to initiate this while in the ICU. It's very much expected that there'll be very variable insulin requirements and dosing during this time. So it'd be best to wait till the patient is out of the ICU and to then determine a insulin requirement that you can then use to decide on a discharge dose of insulin.